Professor Medhat Osman is usually coming to our Congress every year. I think he is one of the eminent people not only in PET-CT but in different aspects in nuclear medicine. Yesterday he gave us a very good talk about PET-CT. And today he is talking about update in nuclear neurology, that in order to know that he is not only a PET-CT man, he is a nuclear medicine, a good nuclear medicine physician, as we all know. His lecture is usually very informative to all of us. I myself, I learn a lot from him. So I think everybody in this session will learn a lot from him. I hope that you get benefit from all what he will talk to us about nuclear neurology, because I think this is a very good challenging aspect in nuclear medicine. Please start, Dr.
Thank you so much for the kind introduction. It's always a pleasure to be here, and again I want to thank the organizing committee for giving me the opportunity and come and talk and socialize with all our nuclear medicine family in Egypt. I wanted to talk about nuclear neurology because it's one of the subjects that we always focus on PET-CT and oncologic applications, but we rarely have dedicated sessions for nuclear neurology. And there are a lot of activities in that area where I work at St. Louis University, and that's why I titled this slide as What is New at SLU. So the outline is we're going to talk about Alzheimer's, we're going to talk about traumatic brain injury, seizure, and we'll end with Parkinson's disease. As we all know, FDG PET is avidly taken up in the brain, and we're all familiar with the normal physiologic distribution in the brain. Brain takes up to 25% of the total metabolic energy in the body, and that's why it has the highest glucose consumption. And the FDG distribution reflects that, and most prominent uptake is in the gray matter with a gray matter to white matter ratio of 2.5 to 1. This is a study that actually a colleague of all of us that worked on it, Hussein from earlier when he was in St. Louis University and presented at the ESNMS. I'll just show you some example of, this would be the classic mild to moderate Alzheimer's disease, where the areas that the arrows are pointing to relative hypometabolic activity indicative of that. This is a more advanced disease where it's more bilateral and more severe reduction in uptake in the bilateral temporoparietal region. This would be an example of a dementia of a different type, the frontotemporal dementia, whereas the arrow is pointing to a different distribution. And this would be an example of another cause of dementia, the multi-infarct dementia, in which having a CT information on board is very helpful, not only for using the CT for attenuation correction, for using it for localization of lesion, but then also in increasing the confidence level in seeing areas of hypodensity in the CT indicative of prior infarction. So when we use CT in PET-CT in brain imaging as well as CT in the SPECT, frequently it is to rule out other potential explanation for the abnormalities that we're seeing on the metabolic side of things, whether it's PET or SPECT. Now, if you look at the Alzheimer's disease as far as the progression, it has a predictable pattern that within 10 to 20 years, we start with mild forgetfulness, and I'm probably somewhere here right now with forgetting things, but when it is Alzheimer's, it kind of continues progression within a few years. It's kind of predictable pattern that's slow but definitive in terms of the progression. This was published back in 2010, but still the data is valid. If you look at how, if you fast forward to 2050, it's predictable that the number of people that would be affected by Alzheimer's type dementia would be exponentially getting higher and higher, and even more in low to middle income countries than high income countries. So here you have a steady growth, here you have even a higher level of growth. If you look at it as a dollar amount, the estimate is in 600 billion. And just to give a sense of the magnitude of this, if Alzheimer is a country in terms of the expense, it would be equal to the whole budget of Turkey. So it's a huge amount of money that the world is investing and is costing, whether it is the patient themselves or taking care of the patients to deal with it. And just a little bit of historical background in looking at where the whole thing started. On the left is the infamous Dr. Alzheimer, for which the world is indebted for discovering that ugly disease. And on the right, we should be just as indebted. This is the first patient that the whole process of diagnosis of Alzheimer. Her name was Augusta Dieter. I don't speak German, so I'm sure I'm butchering the pronunciation. But this patient presented in her kind of mid-40s, late 40s, to Dr. Alzheimer with forgetfulness, and he called it disease of forgetfulness. And then they did the autopsy after she died, and that was the first time documentation of the whole hypothesis of plaques and tangles. And since then, that has been the diagnosis. But unfortunately, the definitive diagnosis is through autopsy. If you look at the amyloid deposits, it's kind of very low level at the pre-symptomatic, but somewhere, and we don't know exactly where, it will just suddenly cross a threshold and start peaking in the accumulation and then plateauing after that. But that is caused, at least that's the current hypothesis, of going to a symptomatic phase and leading to advanced dementia. So it's the amyloid deposits, and for many years we were not using FDG PET to diagnose Alzheimer's because people would say, so what? There's no treatment for it, so what's the point in treating it? Because the focus in the therapy was the cholinesterase inhibitor when we were using it when the patient is symptomatic, which means at that time it's quite late to treat these patients. So now there is a whole new line of thinking, which is disease modifiers, in which you are attacking the disease at a very early stage, and the hope that the combination of the disease modifiers that you may not need to give symptomatic, or that if you combine these, your efficacy will be significantly higher. And I will focus more on prasinezumab because that is the study that we're involved in. So this is the hypothesis, is that if you look at the cognitive function against time over a 2 years period, if you give placebo, this is the cognitive function will decline steadily. If you give symptomatic, then it will decline in a parallel fashion, but in a slower rate. If you give disease modifiers, then you are slowing this, and if you give both, then you will end up by slowing the disease significantly more, at least. But there are some people who are hopeful that actually you can not only abort the process, but reverse it through getting rid of the amyloid deposits. And that's the whole concept of the immunotherapy in Alzheimer's disease now. So the idea is that we know there's amyloid deposits. If you give monoclonal antibody therapy, that would not only abort the progression, but even start clearing some of the amyloid deposits in the brain, and that results into potentially reversing the process itself. So think of it as potentially vaccination against the Alzheimer's disease. So studies in animal level is very encouraging, and basically this is the conclusion from a large animal study that active immunization prior to the onset of Alzheimer's disease, like pathogenesis, prevented cerebral amyloid, beta-amyloid accumulation, and cognitive impairment. But that, as usual, its extrapolation from mice to humans is somewhat tricky, so you need to validate that in humans early. Clinical evidence is supportive of that, but there is a question of how you are going to assess that response to therapy. Are you going to use testing patient neurocognitive functions, which is somewhat subjective and multifactorial? What will be the end point and the objective criteria that you're going to use in documenting the response to therapy. So this is based on neuropsychological test battery, and you can see that the pink is the responders and the blue is the placebo, showing that when you give Parkinson, you actually see a great deal of response in terms of the neuropsychological test battery. But it became the standard now is to use imaging as the endpoint in documenting the reversal of the amyloid deposits. And the first product in the market came out of Pittsburgh. It's the PID product, and now it's owned by GE. And if you look on the right, this is the control, and if you look on the left, that's the Alzheimer's disease. So it's kind of the reverse image of what you would expect with FDG PET, that if you look at FDG PET, you'll say this is good, this is bad, but actually in the amyloid imaging, it's the opposite. So you would want your brain to look like this, because that's basically indicative of minimal or no amyloid deposits. But if it looks like this, that's bad news, because that means these areas are potentially going to turn into Alzheimer's. It's not 100% clear cut. You have some overlap, but that's basically the underlying hypothesis of the amyloid imaging. When they used the Parkinson for therapy and used the carbon-11 PID as the way to objectively assess the response to therapy, this is what they came up with, that this is the placebo showing continued progression, continued accumulation of amyloid deposits. But if you give Parkinson, you can see that this is decreasing when you give Parkinson. The problem with carbon-11 is, so this was the effect of therapy in the carbon-11 PID product, that you have this is the screening, and this is week 78, this is screening, week 78, and if the patient is responding, you'll see decrease in the amyloid deposits. If the patient is not responding, then you'll see continued accumulation. So this is the placebo. So you're seeing that this is a continued accumulation. This is the treated, and you can see that it is decreasing. If you compare baseline to post-therapy, baseline, post-therapy versus placebo, it's not changing, when in fact it's increasing here. Now the problem with carbon-11 is that it's very restrictive because of the half-life of carbon-11, and that's why whenever there's a success of something, people will try to turn it into an F-18 based because of the success of the wide availability of successful distribution routes for FDG in the world of FDG PET, CT, oncologic application. So it was a predictable pattern of everyone saying, I want to develop something that's F-18 based amyloid imaging agent and without having to deal with carbon-11. So the flow that appear, or the 8045, is the product in the market now. There are multiple products in the market, but this is the one that we are currently involved in this particular study. This study came out of Hopkins, and comparing two patients that they are both old patients, but one has dementia and deterioration in mini-mental status, and this one doesn't, and the mini-mental status is better. And again, what looks bad is the actually negative study. What looks kind of good to our eyes is the one that actually bad news. But certainly the carbon-11 is no longer being used in clinical trial because it's just very restrictive because of the half-life. So this is the study that we're involved in. This was phase 2 randomized double-blind placebo-controlled multi-center trial. Basically, they are taking patients with suspected Alzheimer's at baseline, imaging them, and if it looks like they are showing the patterns of uptake suggestive of Alzheimer's, then they'll go ahead and treat them with Parkinson subcutaneous injections at multi-dose level. So we randomize people, and we're going to follow up patients for 28 months, and the subjects will receive monthly injections of 1 of 3 dose levels of Parkinson. It's 2, 7, and 20 milligram, or placebo. In terms of the PET imaging, we are imaging these patients 4 times per the 2-year period. One for a screening visit, and this is basically to document the actual uptake, and then you treat, and you start imaging them at 6 months, 18 months, and 24 months, and hopefully showing a pattern of decrease in the uptake over time, and then they're going to look at it and see which is the dose level is any indicator of which would be the best dose, or you're going to have this response no matter what dose level. This is the imaging protocol. It's actually a simple, straightforward. If you do have the tracer itself, you're getting 10 millicurie and you're injecting the tracer IV, and then you're imaging 50 minutes later. There's a lot of monitoring of the patient, because also you have to document if there's any side effects happening, if there's any change in blood pressure, and then so we have to monitor that, so a physician has to be inside. This is an example of the images of the AV45 that we have. This was the baseline study. So looking at it just like any FDG PET brain, it's a little bit deceiving when you look at it in terms of what areas that you would label as abnormal. But the trend now in clinical trial is that you do participate in it, you acquire images, you dictate the report, but you have to send the study in a DICOM format to the center that is running that particular trial, and they have their own team to read it, kind of central read, because they don't want to have variability that I may say is positive, but Dr. Khalid may say, no, this is negative. So they want to avoid that variability by having one team that is very qualified and expert in reading that study. So this is the baseline, and this is 6 months after therapy. Now I have no way of knowing, to my eyes it looked the same, but I have no way of telling you whether this is a randomized to the placebo arm, or to the high dose arm, or to the low dose arm. I have no way of knowing that. That's kind of confidential. But you can imagine that they actually finished enrolling the number of patients, so they met the target sample size, and they are going to continue monitoring these patients for the 2-year period. Then they're going to close the whole study, so now it's closed for enrollment, but they continue following up these patients, and then once all of this is said and done, then they are going to analyze the study and look out for some major publications that are probably going to change how Alzheimer's is being treated in the world in the next year or two. Now, moving to another big, huge area, which is traumatic brain injury, or TBI. As we all know, whether it's from sports or car accidents, or more commonly now, wars. It's becoming a major worldwide, not just in the States, but certainly in the United States, because of all the crazy wars that people are involved in. So the estimates of service members with a clinician confirmed military TBI range from 11 to 23%. So think about that each, whenever you're sending 100, then up to a quarter of them will report some form of traumatic brain injury. And as of 2008, it was out of the 1.65 million deployed, it was 320,000 reporting that with probable TBI. Now the problem is you have another entity called post-traumatic stress disorder, which is one of the most common comorbid psychiatric disorder in the same population. It becomes challenging how you make that distinction between these two groups. This is just to show you, based on a study in 2010, that whether it's a mild or penetrating or moderate, it's a steady increase in the number of reported cases. And the problem is when you think of what are the types of traumatic brain injury, you don't have a standardized classification of it. Each institution and each entity have their own classification of what constitutes traumatic brain injury and how would you classify it. This is the Department of Defense, DoD, that's their classification, so they look into traumatic brain injury and divide it into penetrating, severe, moderate, mild, and not classifiable. But it's huge, and especially if there is a brain injury that results into loss of consciousness, then that's bad news, because studies showed that if you have loss of consciousness, then you'll have about 44% of these patients will meet the criteria of post-traumatic stress disorder, versus 27 if there is no, there's altered mental status, and 16% from other injuries. So losing consciousness during a significant trauma is bad news in the settings of the Army. So if you look on your left, this is the TBI, military TBI, where you have confusion, loss of consciousness, amnesia, neuropsychological symptoms, and neuropsychological dysfunction. If you look on the right, that post-traumatic stress disorder, where you have re-experiencing of trauma, avoidance and numbing and increased arousal, but then you have a lot of overlap here, cognitive symptoms, emotional affective symptoms, physical and somatic symptoms. So the question is how you're making in a post-concussive syndrome distinction, because one is primarily psychiatric issues and this is actually organic. However, in some of these patients you image them and there is no physical evidence of the abnormality. So the question, can imaging help in that? So whenever there's a TBI, you have significant deficits as far as attention and executive function and learning and emotional and self-monitoring. These are all largely non-focal, but are processes dependent on network in brain regions. So again, there's just a lot of overlap between these two entities, and a lot of it is self-reporting symptoms. You rely on the patient asking them, how do you feel? And clearly, in these patient population, that can be very confusing. So the question is, how do you address this gap in the literature as far as making a distinction between post-traumatic stress disorder versus traumatic brain injury? What is reversible and what is not? What is psychiatric versus what's or physical organic problem? So the aim of many studies was to attempt to address some of these diagnostic issues and to better understand TBI, post-traumatic stress disorders, and being able to would they both happen at the same time? Can you make a distinction when it's purely post-traumatic stress disorder versus an actual traumatic brain injury? So the functional imaging has potential to serve as more objective and more sensitive test to diagnose TBI. Now, the problem is historically they are using MRI in this imaging, and there's some scattered reports in the literature as far as how FDG PET can help. But this is what we are trying to do at St. Louis University, where we have the what's called Advanced Neurosurgical Innovation Center, or SANIC. It's a multi-million, multi-year funded from the Army in the U.S. that basically we're having these patients undergo MEG, which is magnetoencephalopathy, which measures the currents that are coming, very low-level currents coming out of the brain. And we're also doing functional MRI, we're doing FDG PET, we're doing extensive neuropsychiatric testing and then putting it all together. MEG basically is based on, because I don't know if there's any MEG in Egypt, so I put this slide. So basically there are currents in the neurons create very tiny, teeny, tiny magnetic fields that are in the femto Tesla level. So it's not something that you can detect normally. The MEG is a kind of what's called SQUAT, which is superconducting quantum interference devices that can detect these very small magnetic fields. And the nice thing about it, there's no contraindication. So we have the MEG unit next to the FDG PET center, to the PET center. So basically, patients can have the MEG and then come have the PET, or go to the PET and then go to the MEG. So there's no contraindications from doing both at the same time. So so far, the goal of this study, and we accrued many of these patients now, is to have 50 TBI military, 50 civilian TBI, because we wanted to look whether there's any difference between civilian and military TBI with that versus age and gender matched control, or recruited from the community, and the veterans are recruited nationally. These are all age, gender, and disability matched groups, and all injured after January of 2002 and are more than 6 months post-injury. So things calm down if there is any changes that's taking place in the brain. And all level of injury severity, but majority are mild, just because when it is severe TBI, it's very difficult to image these patients because you're not going to get any cooperation from them. So the idea is to bring patients, day one, they have extensive neuropsychiatric testing. So this is like 7 or 8 hours of testing and asking questions and filling forms. And then day two, they have the FDG PET, they have the MEG, and then they have the MRI. And then we're going to try to put all of these things together and trying to group patients that hopefully see a difference. So this is an example of how the MEG images when you fuse it with the MRI and showing that there is some active signals, in the brain. This is some prelim analysis of the study showing a difference between in the cortical thickening based on the MRI. So this is MRI fused with the MAG information, what's in the red, a normal volunteers control group, and then what's in the blue is the military TBI, and you can see difference in the cortical thickening, meaning that you can use that in making that distinction. Now this is PET co-registered with the MRI, but then also we are fusing the PET together to have kind of group of what the PET would look like for the controls, kind of morph them all together, have one PET that describes what's the normal control would look like, what's the military TBI, what's the civilian TBI, and what's the mild versus moderate TBI. So this is kind of when you create an atlas, putting all of these things together and have the summation image. This is actually data that was just emailed to me literally on the 21st, showing a prelim from the PET, showing a difference in the thalamic uptake between this is the left hemisphere, this is the right hemisphere, and this is normal versus TBI, and you can see that the thalamic uptake is less in the TBI group in both the right and the left thalamus. So we're going to monitor this based on 16 military cases and 18 normal. So we continue to accrue data, but I think within the next year or two, there will be a large publications describing that, but it's a very hot subject right now in the U.S. Now this is, as you can see from the multi-imaging modality, this is a large group. My part in it is the PET imaging, but we have a lot of neuropsychiatrists and a lot of radiologists and actually even neurosurgeons. So this is a large group of people involved in this, and that's one of the big difference, from my opinion, about having a study like this done in the U.S. versus the studies that are taking place in the Middle East in general, including Egypt, is the ability to put together a big team working together without having to have who's going to be the leader in the race of the time there. So moving to epilepsy, as we all know, we use the nuclear medicine for pre-surgical evaluation of these cases, and we have ictal PET, interictal SPECT, interictal PET, and at the research level we have the ictal PET. We don't have to worry about that. Just to show a classic example, 24-year-old male, they have refractory seizures since childhood. EEG showed left temporal origin. Here's the MRI showing left mesial temporal sclerosis. And then you have the FDG PET showing again the same decrease in the left temporal region. So that will be consistent with epilepsy in that area. So that's comforting for patients to undergo surgical resection of that area. And I've seen a lot of these patients where they take a big chunk of their brain and they are functioning normal and the seizure is gone. So you would think that that chunk will negatively affect the functionality of this patient, but somehow the body is able to recover completely. But it's just to make sure that they are taking out the right piece of the brain, because this is not an oops, you cannot say, I made a mistake, let me take the other part out as well. This is a study that I was involved in 2 years ago that basically showing that even when you have ictal SPECT and interictal SPECT as well as interictal PET, you have the phenomenon of propagation, where you can have an area of seizure activity, but that activity may propagate to neighboring areas, and that's why the exact pinpointing or localization of the seizure focus can be challenging in some cases. This was a study that we presented at the RSNA a few years ago, trying to put it all together, where you have the MAG information, the interictal SPECT, the ictal SPECT, the interictal PET, as well as EEG and MRI. Would you have higher accuracy if you put all of these imaging modalities together than using a single one? So I'll show you an example. A 63-year-old female with long history of complex partial seizure. Seizure frequency was every 2 weeks. I've seen some of these patients, they're living a miserable life. Typical symptoms: confusion, stiffening, right upper extremities, occasional clonic jerks, right hand trembling, and tongue biting. video surface EEG telemetry showed 9 events of complex partial seizure likely originating from the right temporal region. So the EEG is showing it's probably the right temporal area. MRI was negative. There was no structural abnormalities, so that's comforting to know that you are after the right target in terms of seizure. There's no mass, there's no tumor. Now you put the MEG information on top of the MRI, and it is showing left hemispheric slowing prominent in the left temporal lobe, which is the green circles you're looking at here. Suggestive of paroxysmal activities. These activities, however, are not epileptic form. Bottom line, the MEG was not very helpful in this case. Now you do the interictal PET and you see mild hypometabolism in the right anterior lobe where the arrow is. It's subtle, but it is there if you compare the right to the left. You do the ictal spect and the interictal spect where this cross is meeting, and this is fused with the MRI, and this is showing right anterior temporal lobe with the interictal showing right temporal lobe as well. So now you have higher certainty that even though the EEG was not as helpful, the MEG was not as helpful, but to put it together, that the interictal PET and the ictal and interictal spect suggestive of blaming everything on the right temporal lobe, even though the MRI and MEG did not help. So patient giving the higher confidence in this case based on multimodality. So the patient went ahead and had underwent a partial right temporal lobectomy, and it showed the pathology showed non-gliosis, and the EEG intraoperatively showed no seizure activity after surgical resection, which is indicative of good results. I want to go over time, so I'm just going to skip the second case because it's kind of the same phenomenon, although it just showed you in this case that there's some disagreement because different imaging modalities show different sites of abnormalities. So you have, it was basically pointing to bitemporal seizure activities, and that means you cannot operate on these patients. You're not going to remove bilateral temporal lobes. So basically, the patient was under medical treatment. Now, if any of you, and I certainly was at one point in time involved in ictal spect imaging, it's very challenging because you have to admit the patient, you have to try to time when the seizure activity, basically the patient has to have an IV and they tie their arms down and someone is monitoring 24/7 this patient, and as soon as they see seizure activities, they run into the room and do the injection. Because if you don't inject within a minute or two of the seizure activities, then your accuracy will take a nosedive. So if you wait for 5 or 10 minutes to do the injection and you're looking for an IV access, then it's too late. So it's not easy and it's expensive, and sometimes you admit patients and then they don't have seizure activity, so you just watching them, they're watching you, and nothing is happening. So what we're trying to do now is trying to see, can you use the interictal MEG with the interictal head and the interictal spect? Can we eliminate the need to have ictal spect, which is reportedly has the highest accuracy, but it is the most challenging in coordinating. So this is the study that we will be doing. Now, this is as far as research level, but what's in the real world now is the issue of PET-MR. And I like this slide because it's going to give you an overview, and I think one of the presenters yesterday presented something similar to it about where is the kind of the power of each imaging modality. So we are kind of somewhere more on the molecular side of things and less of the anatomy. MRI is more of the anatomy and less of the molecular. You put them together and you have the best of both worlds. That's basically the, if you look at the PET-CT images, the CT typically will add little to the PET information in the brain. It adds more for the rest of the body, and that's why still the standard of care evaluation of anyone with suspected brain lesion is to have MRI, not a CT. So if you put the PET and the MR together for the brain, that's the best combination that you can think of. And it's now debatable, and there's a lot of people who are feeling it's a hype of the PET-MR outside the brain, but there's no doubt, it's not debatable at all, that PET-MR is going to be a superb powerhouse in the brain. So clearly you can evaluate a lot of the abnormalities, and including seizure will totally change things once you have access to PET-MR. This slide is from Dr. Osman in the RSNA in 2010 in the case of epilepsy, 19-year-old. But you can just see the exquisite information that you get from the PET-MR brain imaging. Now moving on, I didn't want to just talk about PET, so I'm going to talk about SPECT a little bit, and general nuclear medicine, Parkinson's disease. So it's a chronic and progressive movement disorder that belongs to conditions that called motor system disorders. It's characterized by bradykinesia, rigidity, tremor at rest, and postural instability. However, some of the symptoms may appear in other disease processes, and that's why the distinction can be challenging in some cases. The diagnosis in many cases is clinical, but in some cases it can be very challenging. In the U.S., the data reports that it's 50 to 60,000 new cases of Parkinson's disease diagnosed each year, adding to the 1 million people who currently have Parkinson's disease. We know that anatomic imaging is not helpful at all. You do MRI, and it's totally normal in these cases. So you're doing the MRI just to rule out potential other causes for the abnormality, but not that there's anything diagnostic for Parkinson's disease. A lot of data in the literature regarding the role of dopaminergic imaging in patients with symptoms of dopaminergic system neurodegeneration, and that is the system that we blame Parkinson's on. There are different tracers in the FDG, in the PET world, as well as in the SPECT world. A lot of the PET world is the F-DOPA and carbon-11 DOPA, and this is kind of more on the research side. It's not paid for. Now, the DAT scan, or iodine-123 ioflopane, is something that has been around in Europe for a few years, but was recently approved in the U.S. In 2011. And not all centers are approved because you go through an approval process in terms of the training and validation of the equipment. It's a product that's owned by GE, and GE will send their team to validate the systems and the ability to acquire the images in the standardized protocol according to their instructions. But it's a cocaine analog substance, and that means big, huge problems in terms of the handling of that, because basically it's cocaine. So it's just, you can imagine the pharmacies at the hospitals freaking out when you say, I want to start this, and then they look it up and realize it's a cocaine product. So every single nanogram has to be accounted for. So from the radio tracer's point of view, it's the good old iodine-123. It's not a problem, but it's the chemistry of it being a cocaine product that's problematic. But basically, it demonstrates the location and concentration of dopaminergic transporters and receptors in the synapses. This is a publication that came out earlier this year from the ESNMS practice guidelines. If anyone is to start this, I would recommend that you read this particular article. It describes step by step of how to do that particular study. Not the image acquisition as much, but in terms of image interpretation indications. It's actually a simple study. A simple way to remember it is you give about 4 millicurie and you wait for about 4 hours to do the imaging of these patients. We have sometimes a problem with patient cooperation because of the tremors. So out of 50 patients we did so far, only one that we had to reschedule because it was just moving too much. It's very expensive. It's about $10,000 if I remember correctly. So you don't want to have a dose and you say, oops, I cannot do it. Sometimes it's helpful to call the physician and say, do you think the patient will be stable enough to undergo this particular study? The idea is that it's a radionuclide imaging that evaluate the integrity of the nigrostriatal dopaminergic synapses by visualizing the presynaptic dopaminergic transporters. So this is an example from that particular publication showing the normal distribution. It's all about the pattern in the caudate and putamen, which looks like a comma shape. So if a normal patient should look like that, this is by definition abnormal because this is start looking round, oval shape, and you start losing the putamen aspect of things. This is also beginning of being abnormal. Sometimes you have the abnormality bilaterally, and sometimes you have it unilaterally. Here is a more advanced case of abnormality. Again, on the right side, the left side is, again, start losing this comma shape. This is definitely abnormal. Nobody would read this as normal. Now, this is from the paper, but this is from actual patients that I imaged. So this is the normal distribution where you have clean comma shape. So just keep that in mind if you compare it to a patient like this where it starts being oval and round. So this will be abnormal. It's not as straightforward. In some cases you can have kind of what's called kind of indeterminate or intermediate, where you start having a little bit of difference, but is it bad enough to call it abnormal and label this patient as classic Parkinson's type, or I don't feel comfortable, and the data and literature saying that you can have 10 to 15% of cases that legitimately should be labeled as indeterminate. And you can have normal variables from one patient to another. So there are some studies, for example, for this particular patient, we tried to, some people are recommending doing some quantification to try to get some, what's the difference? Is it 10%, 50%? So you go volumetrically trying to capture all the caudate and putamen counts and count density and uptake in the right side versus the left side and see what is the difference. In this case, if I remember correctly, the difference was about 10%. It was 167 versus 178. So again, that did not persuade me one way or another, so we still called it indeterminate. There's no database to describe what is the normal uptake in the caudate and putamen. When would you call it abnormal? So it's still subjective. And there's a large European database of normal healthy subjects that should be published in 2012. So that will help at least establishing what is the normal distribution and uptake in the caudate and putamen, because before you label anything abnormal, you have to be comfortable with knowing what is the normal. And there is a similar study that may be coming, a database that may be coming out of the United States. Now, contrary to the belief, PET and SPECT is actually growing. And a lot of the growth is going to be coming out of non-oncologic application. It's going to be neurology and cardiology. So it's estimated to have been 6.5 billion in 2010, and that will grow to 10 billion in 2015. The combined annual growth rate of 9.4% over the next 5 years, and PET and SPECT installation of, it was about 3,691 in 2010, and this is expected to reach to almost double in 2015. So I just encourage you that in the area of cardiology and neurology should deserve more attention from our specialty for sure. And there is a lot of interest. This is from just a random from the March issue. Just looked up just to show you that there's a lot of excitement in the area of neurology, nuclear neurology. Just someone sent me this published in March 15, 2012 about a new PET scanner that's dedicated for the brain. It's based on semiconductor detectors. They're using that in target volume delineation in patients with head and neck cancer and esophageal carcinoma. So what's in your right is the new brain-dedicated PET, and this is the conventional PET scanner, and you can see how the images are crispier, and then they end up by decreasing the tumor, the target tumor volume by a significant percentage in that dedicated PET, because they can actually delineate the tumor much better and clearer. Now, this is also just from the most recent issue of the JNM talking about clinical validation of another EpiPen-based amyloid imaging agent Just to show you that there's a lot of excitement in that field. So this is Alzheimer's disease patient, and this is normal controls. Again, this is the normal, and this is the abnormal case. From the issue, the March of 2012, this is regarding the tracer that we're using the fluor the pair of the AB45, just showing that they can make a clear distinction between normal subjects and patients with amyloid deposits and dementia. And they are using multiple levels of tracers. Remember, we're using 10 millicurie, but they're showing that you can actually make a distinction between normal and abnormal, even at the level of 3 millicurie. So I will stop here, and I'll be here till tomorrow to answer any questions you may have.